this is crazy. It's supposed to be healthcare.
And it was just mind-boggling. There's such a great opportunity to lead in this space.
Find a partner that meets your needs.
Put yourself in the patient's shoes.
And when patients understand, patients are happy.
Organizations that succeed in this are going to be the ones that bring in RCM.
We're always looking for chances to do better.
The problem in our industry is
all right. Hello, everybody. Welcome back to another episode of Vendor Voices. We're excited today to have Corey from Protego Health. How you doing, Corey?
Well, thanks. How you doing, Ryan?
Doing great. We're happy to have you. Excited to have the conversation. As we always do with Vendor Voices, we dive right into the Snapshot Challenge. Corey, are you ready?
I am ready.
All right, man. Here we go. 5 minutes on the clock. Question number 1. Who is Protego Health?
We are a software company using AI to prevent and appeal denied medical claims.
All right. Question number 2. Who does Protego Health serve?
We serve primarily independent specialty provider groups and primary care and RCM companies. And through the RCM companies, we're starting to address hospital claim denials as well.
Understood. Question number 3. What problem is Protego solving?
When it comes to denials, providers are basically guilty until proven innocent. The payer uses an automated adjudication engine to deny, and then the provider has to use a person to appeal. So we want to even that playing field. There's an aspect of this that is somewhat like taxes. The government knows how to calculate what you owe, but you have to figure it out. And if you get it wrong, you're penalized. We try to reverse that paradigm by bringing the rules engine to the point of claim creation to use all available data that used to be spread out across the internet to live in one place. And of course, that place is where the claims are created. And we're now actually moving even further upstream to the point of clinical note creation, where the provider is actually creating the note, where we can vet adherence to guidelines prior to the provider closing that note.
All right, question number 4. How is Protego solving that problem?
Well, it's a quick answer and much harder to do, but software is the short answer.
Fair enough. I'm sure we'll dive deeply into that in the rest of the conversation. Final question. How is Protego solving that problem differently?
Our goal is minimum friction. A lot of people are asking providers to implement costly and time-consuming integrations, asking them to believe that AI is going to solve the problems. We found a way to circumvent this costly and time-consuming integration while still being able to serve as an in-workflow tool for any web-based EHR for the most part, ECW, ModMed, Advanced MD. So I would also say that building the foundation of the model on actual policy as opposed to historical data allows us to change with the changing rules and guidelines. So that's an advantage above, let's say, a clearinghouse where you're manually creating those rules when you learn that you have been wrong based on a new guideline that was rolled out. Whereas for us, it's the technology that is detecting those changes and automatically updating the software to tell you the most up-to-date rules within your native workflow, and layering on top of that the data from historics to let you know if A is better than B, if both of them qualify under the policy.
All right. That's the Snapshot Challenge. Corey, you did it. How you feeling?
Feel good. I feel like I also did it quicker than most. No, that's got to be like 2.5 minutes.
It totally varies. The 5 questions in 5 minutes is just catchy, right? It probably shouldn't take 5 minutes. I loved a couple things you said though, right out the gates, man. Guilty until proven innocent. Obviously, I don't love that that's true, but it feels so true. Very relatable. And then the taxes analogy, I never really thought of that one, but I think prudent. Very interesting. But before we get into any more detail, Corey, I want to give you the opportunity. Why don't you tell our listeners a little bit more about you?
Sure. Well, me, insofar as it relates to this problem, is, I grew up in Westchester, New York, the oldest of 4, and my younger brother struggled with colitis throughout high school, and his senior year, it really came to a head when he had 8 surgeries that led to him spending 100 days in Mount Sinai Hospital. And the cherry on top of all of that was $1 million in bills that our family was hit with. So this was kind of something that early on became part of my reality and my understanding of the way U.S. healthcare worked. So it was always something that kind of sat in the back of my head. I went to school in Philly at Penn, From there, I actually went into the military for 3 years, and pretty quickly after coming back from the military with a brief stint in ad tech in Brazil, I was working within the healthcare space. Ran sales for Parachute Health, was the seventh hire there, and spent time in a number of other different healthcare provider-facing companies, and was always kind of fascinated with this problem of how U.S. healthcare works or doesn't work, and how that affects the patients that it is, in fact, meant to serve. So, service has always been something that's important to me, whether it was the military, whether it was doing volunteer EMS with Central Park Medical Unit in New York. It really felt like a way to do well and do good and to contribute to making things better. And so for me, the culmination of all those jobs, most recently selling on a PM basis into payers actually, was a more complete picture of the system and what's important to providers, what's important to payers, where the rubber meets the road and where that friction occurs, which is really at the point of claim submission, which is maybe I asked permission for this in the form of a prior auth. I submitted the claim for this thing that I did, and now I'm asking you as the insurance company to pay me. And that's where kind of all the real problems begin. And so honing in on that particular snapshot of the life cycle of a claim in the general healthcare journey, I thought was an interesting way to try to help providers and the patients that they serve fight back against what appears to be an increasingly automated engine that is aligned against that cohort.
Yeah, I think there's enough evidence out there to show that it is incredibly automated on the denial side from a payer standpoint. And I think you hear all the time now, we're just in an arms race for that technology battle. On some other podcasts I've listened to, actually now I think it's, okay, at some point is AI just going to be fighting AI? And that's the final point in time in which payers might say, well, now this is actually inefficient for us even too. So let's just drop all the BS. We'll see, I hope. It's interesting. You never, obviously, you never want anybody or anybody's families to have to go through such deeply personal and challenging healthcare journeys as you had with your brother. But I'm curious if that, kind of shaped any of your business priorities or still does today, or any of the product decisions you make, or was it really just kind of your founding story as to why you wanted to do this in the first place?
I think, our entry point into the world of specialty care was GI. I think specifically because of my brother, and a nice kind of full circle moment was our acceptance into the AGA's inaugural incubator in partnership with Matter Health, which we were accepted into late last year. We're the only revenue cycle company in that cohort. And so that was kind of a nice full circle moment. And the let's say, recognition by at least that society of the challenge that denials pose even to clinical care, right? Because for the most part, the other companies are dealing with things that are directly related to clinical care. But the fact is that financial toxicity is clinical toxicity. And if you're a practice doing buy and bill, let's say, and you keep getting denied for this drug that you're buying, you're not going to keep buying it. And it may become the case that the physician's first choice of drug to address your Crohn's or colitis is no longer one that their practice allows them to prescribe because they're not able to get it reimbursed. So I think while it's somewhat distant theoretically from clinical care, I've seen firsthand just how closely related those two things are. And for me, because that's where kind of my family's pain emerged, that was the problem that we sought out to solve.
Yeah, I think the common saying I hear there a lot, you probably heard a million times too, no margin, no mission. Right. So let's get back into Protego. Make it real for us. So tell us maybe through how the technology actually works. I think you did a good job in the Snapshot challenge of kind of explaining how it integrates a little bit, but take us a little bit deeper, put me in the shoes of somebody actually using it. What does it look and feel like? How am I operating Protego's platform?
Yeah, I mean, the idea from the start was to be native. And so if it's a web-based approach, we have a way to basically tag alongside that user experience so that they're never leaving their native work environment. And we are bringing in to that environment all of the things that an RCM specialist used to have to check that was outside of that work environment, whether it's the CPT, ICD-10 guidelines, the MEUEs, PTPs. There's just so many different coding guidelines and billing rules that govern the way a claim needs to be filed in order to increase the chance of payment. And some of them are payer specific. So you can file a claim correctly per the coding guidelines and still get it wrong because United wants something that's slightly different from Aetna. And so even when we've seen cases of major EHRs like Epic that claim to do some version of coding edits in the right rail, we haven't seen that drop down to the specificity of the individual payer policy. And that's where I think there's an opportunity to really distinguish ourselves and kind of where we started, right? So that idea that as you are doing what you always do in the place that you always do it, instead of having to go to Coder Select or one of these other websites and kind of queue in information, you can get all the information that you need at your fingertips, like your VP kind of sitting over your shoulder and being like, do this, not that. You're missing modifier 25. That's not a primary first diagnosis. Choose from one of these. So really trying to get ahead of the 8-ball when it comes to denials. And now we're doing the same for providers, right? Which is sitting inside of their workflow as they're creating that clinical note and saying, hey, you didn't mention the length of the sutures, right? And that's critical no matter how you're going to bill this for reimbursement. So things that cause downstream problems, trying to get ahead of them and as far upstream of them as possible. But then, of course, recognizing that denials are inevitable, right? They are, in fact, a business line for some payers. And so how do we try to make that process of overturning them as easy as possible for providers? And in essence, for that use case, we're able to use kind of 3 distinct data sets. The first is the claim and the payer's response, which kind of cues us in to what policies are relevant. The second, our software finds itself, which are those policies that govern payment. If it's a drug, it might be the FDA guidelines. Often it's the individual payer clinical policy bulletins. And then thirdly is the medical record, right? Which is the notes about what actually justified that claim. And using those 3 distinct data sets, we can drill down and say, this was in fact medically necessary despite the denial code. Aetna says that you could provide this sort of treatment if you have one of these 3 things. And as you can see on January the 2nd, the doctor clearly documented thing 2. Here's the quote, right? So really kind of bringing it to a head, like in a very easily digestible way. I've often seen medical necessity appeals that go something like, you deny this for medical necessity, it's medically necessary, see the attached documentation. And it's, 5-page note. And when I think about how things work on the other side of the table, where a claim analyst for a payer might have an hour to go through 50 claims, they don't necessarily have the time to read that documentation, and they're not going to get fired for saying no, right? How easy can you make it for the person working for the payer to see exactly why you are correct in a quick and efficient way, so that if they are acting out of any degree of good intentions, they can just say yes and move on?
Yeah, that I like how you close that out there. We should always be trying to make it easy for our users, and you're certainly trying to do that through your integration. But also making it easy for the payers. I like that, right? At first, you're like cringe, make it easy for the payers, but really, it's make it undeniable for the payers, or make them not be able to say anything other than, okay, yeah, you're right. And that's a good rule of thumb for anything, right? When you're talking to anybody, you're trying to convince anybody of anything, just make it easy for them to agree with you.
Yeah,
Show them the proof.
don't back anyone into a corner, right? It's kind of negotiating 101, make it easy to say yes. And the truth is, over 40 states have the right to third-party appeal, which I find that most providers do not take advantage of out of fear of retribution. But, I've heard it whispered that payers do pay attention to the providers that push back and those that don't. And when they miss a quarterly earnings target and there's a need for revenue, like there are easier places to go when the provider is not fighting back, as opposed to one who always appeals and who will take it to the state level if they have solid evidence. And so the way we frame our appeals has some degree as well of, and if you say no, here's all the evidence that we're going to take to the third-party board that pretty clearly states that you're in the wrong here, right? It's pretty undeniable. So that's kind of the underlying unstated threat as well, which is like, we can do this the easy way or the hard way.
Yeah, that certainly makes sense. And thank you for kind of taking us inside of that. I think it's been fun just with a lot of technologies out there to see what used to be called kind of bolt-on technologies to really be, dare I say, like bolt-in technologies, and a lot more user-friendly, just to bring those many user knowledge bases into one place. So that's fantastic that you're doing that. But the problem of denials is not new. We talk about it every year. Every year I've been in revenue cycle, I've been talking about it, but it's growing and it's changing. There's also this problem of having readily available and easily digestible information. You mentioned medical necessity guidelines, policies, contracts, the actual claim information itself, medical records. So why do you think it's taken so long for someone like Protego to create this convenient reference tool to fight these denials?
Well, denials were always a problem. I would say that the dramatic increase in denials over the past 3 to 5 years, whatever you want to call it, has really elevated their importance. Whereas before it was kind of a back office problem and the cost of doing business, when it's 3 to 5%, you can make that claim. When it's 15%, it's a lot harder, especially in a low margin business like healthcare. The average health system has a margin. I think it was 3% before COVID. I have no idea what it's at now, but it's not high. And so the fact that they have become so prominent and so challenging certainly elevates the need to solve the problem. But if you look at that in combination with technology, previously it was not necessarily easy to surface all of these disparate guidelines and have AI or agents constantly scanning them for changes to then bring them back to that point of workflow, right? It was a reference tool at best, right? Where you could basically manually check these things. And that's where clearinghouse edits came in, right? Was I got denied enough times. So I read the policy and I realized that when this, then that, let me create a rule in Waystar here. And then of course, each month you'll get emailed the 25 changes to the clinical policy bulletin updates from each payer, and you'll be expected to keep track of them, which of course is not really viable. And inevitably you'll find out that something's changed when you get denied or when you hear about it in, whatever healthcare publication you're reading, because it's hitting tons of practices, and then you'll make that manual change. So the ability of technology to actually replicate that manual searching effort, I think is a relatively new phenomenon. And as my grandfather used to say, it's better to be lucky than smart. And certainly that was the case for us, because when I started this company in kind of mid 23, ChatGPT wasn't released till the end of 23. And I don't think I had really any idea how we were going to do it. It just struck me as something that should and could be done somehow. And fortuitously, our entrance into the market kind of coincided with the birth of these more effective large language models, because LLMs have been around for a while, but in their current form, they're particularly useful. And so we've been able to ride that wave. It's a first mover advantage, because if you had an existing company and you had existing software, it wasn't necessarily built to accommodate this new way of doing business. And so from day one, we have kind of been cognizant of that and really kind of entered the market on the first possible day that you could since OpenAI was released.
In your grandpa's words, yeah, good job of being lucky there. I agree with him. Smart man. This show was brought to you by Real Partners Consulting, a free-to-provider vendor selection support company. We help healthcare providers find the right revenue cycle partners across technology, consulting, and managed services at no cost to you. If you like what you've heard from today's guest, or if you're looking for any other partner in the revenue cycle space, let us do the heavy lifting for you. Reach out to me, your host, Ryan Downs, on LinkedIn or at rdowns@realpartnersconsulting.com, and I will personally help you find the right fit. Now let's get back to the episode. So getting a bit more granular, you're in the weeds, I know a lot, despite being the owner, founder of your company. What are the most common root causes you're seeing? Maybe we're doing this at the end of January 26. What have you been seeing maybe Q4 last year? What are you seeing early this year?
Everyone talks about eligibility, and what I'll say is eligibility probably remains like the most common denial reason. But, we just looked at preliminary data for a pretty large client. Can't say the name yet because it's still new, but it looks like we reduced denials by between 30 and 40%. And that was primarily from the coding bucket. I mean, that percentage is across their whole business, but that primarily came from the coding bucket, right? As the rules about how you're supposed to code a claim change, and the payer policies that also dictate sometimes the way to code those claims change so quickly, increasingly practices are struggling to keep up with that. And what I'll also say is, if you look, the only real data provided is for the ACA plans. And the biggest bucket, last I checked, across all payers is other. So really, I would make the case that there is no good data on the most common root causes for denial, because the majority are listed as other. And even when you do get a payer who is coding a denial in a certain way, most providers will tell you it's often incorrect. That's often not the problem, right? The first one that's called out. So if you combine the fact that half are not labeled at all, 2/3 of denials are never appealed, but when they are, most are overturned, which indicates that many of those are wrong. You're left with a picture of, the 50% that are labeled by payers are often never checked and not always correct. The other 50% are not even categorized in any particular way. And you're left with just a lot of ignorance as to the real causes of the problems here. So it's very difficult to measure what exactly goes wrong. But what we've started to be able to do is to look at major categories and point the preventative tool at those categories. As we address coding, moving to medical necessity, as we address that, trying to figure out what else we can bite off. So looking at kind of the most common causes and the big pain points of our clients, while medical necessity denials may be less frequent, they're far more time consuming to address. It might cost you the same amount of time as 5 reconsiderations caused by coding issues. So trying to figure out not just where the majority happen, but where the most pain is for the providers that we serve, and trying to get ahead of those to prevent them before they even happen.
I go back to like my early days in revenue cycle where I'm looking account by account, every single note that was ever taken on that account, and systematically trying to categorize the root cause.
Right.
Yeah, having had the opportunity to work with and alongside and ingrained with many different organizations, I see the same thing. There's inconsistent use by different payers at different organizations of what are supposed to be consistent denial codes. And then you get the fun stuff where now they're sneaking in like non-denial denials, maybe more in the acute space, but
Right.
down coding
downgrades,
comes to mind.
downgrades a lot. Yeah,
Yeah.
100%.
Yeah. So still all over the place, but the coding one, at least that you were seeing recently, is that a specific specialty across the board, primary, for those
No,
listening
this was
that might be in a space
groups across dozens of specialties, so it's really kind of across the board.
all over? Gotcha. Okay. All right. So looking ahead, you're an AI-based company here. As mentioned, kind of riding that start wave around ChatGPT. So you well suited to answer what I think is an important question. What do you see as the biggest barrier to widespread adoption in AI, specifically for denial prevention, appeal automation, and other things in revenue cycle and healthcare?
Well, I think in like the health system space, there's a lot of people that are looking for like their one AI play or their solution. And I don't think there is such a thing as like one hat to fit all heads, and that they would benefit from being specific to their needs, because it's really hard to build a company, it turns out. And to get really good at one thing takes a lot of time and a lot of energy. So if you want that problem solved well, you are best off going to the person who focuses only on it. And I think health systems have not looked at AI that way traditionally. And frankly, one of the reasons that we've stayed away from them is just the amount of time it takes them to make decisions, the number of hoops you have to jump through. As a quickly growing company that identified kind of this acute pain point in the market, I don't want to wait a year and a half to get going, right? Like there are provider groups out there that are big with hundreds of providers who understand this pain point, who can move quickly. And so we have found that aligning with them kind of aligns with our ideal timelines, right? Which is a couple of months to talk through it and vet it, but then to start working together. So I really think like the speed with which traditional healthcare and health systems have vetted technology is a great defense against innovation. And then I would say EHRs, who are trying to own workflows and box out vendors. We could look at Epic and Abridge, the big news a couple months back, but just dangling out, oh, our EHR told us that in their next release, they're going to do something like this, is sometimes enough to prevent a large healthcare entity from choosing a vendor who is specifically focused on that. And we're now starting to see that a little bit with the post-acute vendors. And of course, we're not terribly worried because of the history of EHRs not necessarily moving as quickly as the rest of the market, which makes sense, right? They were built to do one thing and they do that thing really well. And when you look at, I think the most successful EHRs like Athena, they recognize that limitation and they say, come on in, vendors, right? Like there's room for you in here. If you do something better than us, then we'd love to bring you right to our customers. So I think that is kind of the winning approach to how you enable AI to proliferate. But that has not been the traditional approach of kind of the gatekeepers of healthcare.
Yeah, I think there's a paradox in the approval process and decision making at healthcare, specifically when it comes to AI, because I think it is critical, not just in healthcare revenue cycle, but wherever, to have guide rails when it comes to AI. And so you do have to do your diligence and kind of preparation for that selection process. At the same time, I've helped organizations make some of those selections, and if it's truly a priority, then invest the time and effort to do so as quickly as possible. Because every day you're working without a solution that you've seeked out is a day you're working inefficiently and a day of additional revenue leakage. So I'm with you there. Speed to power safely.
Hmm.
I actually had a conversation with someone this morning. So again, we're shooting this at the end of January. I'm hearing some chatter about something you've mentioned, which is not a new thing, but it's getting more attention, I think. Systems like Epic, EHRs, because they can't be the best at everything, to your point, should be concentrating on what they needed to be in terms of an EMR and an EHR. And they're not able to put in as much time in building their AI solutions that they've at least promised to start on. And so what used to be maybe like their solution is a little bit worse
Right.
than the other solutions out there who specialize in focus. Now that gap seems to be widening. And I'd love if listeners out there who are leveraging the EHR AI out there to tell me if that's right or wrong. It's just what I heard from some folks that were out at a 1,000-person conference last week. It seems to be a lot of chatter.
Yeah, I think I've been here since I've been working for startups that have sold into providers. It's a question that I've always heard and probably has always been asked, which is, why can't the EHR do this? And it's a question of focus, right? If you're an ambitious founder, you're obsessing over this one problem, every angle of it, the workflows, the experience of the users. And Judy, with all due respect to the empire that she's built, is not going into hospitals and sitting next to case managers and nurses and saying, show me how you file a claim, right? It's a 25-year-old analyst who's working with that particular hospital who may be incredibly intelligent, but doesn't have the same vision and drive as a founder, and especially not the same one as Judy. And so the things that Epic does well, it does really well. And as you noted, right, as technology grows more quickly with AI to kind of boost it, I think you're going to see that gap widen ever more as the people who focus on very specific problems prove that it's worthwhile to be working with, let's say, a more fragmented group of vendors because of the uplift it provides to your most critical infrastructure. And there's another point on that, which is we took the approach early on that replacing humans is not the right move in revenue cycle. It's too critical to the livelihood of any given business, right? This is literally what keeps the lights on. And so the idea that people are going to trust AI to fully take over that process, we thought was many years down the line, and we didn't want to be selling ahead of that. So the way we built our tool is to try to make people more effective. And we think about like putting the Iron Man suit on your best RCM specialist to allow them to do far more than they could beforehand, while still utilizing their discerning human skills to make real judgment decisions on A versus B, B versus C. And I don't think AI is yet in a place where it can fully replace the human in the loop. And so we haven't tried to. Our goal has always been to empower provider groups who rarely have enough staff to address their existing claim volume to do what they're already doing more effectively. And if they want to grow and scale, to hopefully be able to do so while maintaining the same number of administrative staff, but being able to address more providers as groups consolidate and get bigger.
I agree. I think everybody's looking for AI to be the silver bullet and to be a replacement, whereas it should be considered, at least at this point in time, more technology, right? You didn't, we'd say that about bots and RPA and automation, but not to a degree of, let's get rid of our entire staff type of thing. So I'm with you. Let's upskill the workers we got. They have an incredible amount of knowledge. Though I do think 2026 is kind of the year that we're going to see a real material, impactful movement from AI that suggests and guides to AI that does, that executes, and that agentic AI movement. Just given how exponential the growth of AI has been over the last 3, 6, 9, 12, 24 months.
Right.
It's pretty crazy, even just in my very beginner level use of things like ChatGPT. So I'm very interested to see where that goes. Though I don't think it can ever take away fully the need for human in the loop. Um,
Well, yeah,
so
especially in revenue cycle, because you're there needs to be a human's name on the claim, right? That's the other thing. It's like if it's a self-driving car, who's responsible if it gets in an accident? And so one of the pushbacks to like true automation in RCM is like, well, whose fault is it if you add a code that doesn't belong there, that's upcoding, right? Like, who's to blame? So for us, we've taken the approach of like, we want to bring all the information to bear in a succinct, easily understandable way and still allow the professionals to make the right choice with full information, as opposed to, writing back into the clinical note and changing the provider's words. We don't feel that's our place. The best we can do is prompt them in a way that allows them to get to the right answer.
Yep. No, well said. So I think we probably touched on this, but just to kind of recap in terms of advice, trying to be actionable for our listeners out there who maybe are in organizations that are a bit slow to adopt AI, but they want to see that change. What advice do you have to them in terms of how can they overcome some of those challenges with slowness, or looking for the one AI system that does it all, or really just anything actionable?
I would say, like most things in life, it's the 80-20, right? Like the right place to start is where the pain is most acute for your organization. And if you are cutting down trees in the wrong forest, you're not helping anyone. So the first thing is really to understand like where the process is breaking down in your own revenue cycle and where that's coming to a head. If 95% of your denials are eligibility related, that's a great place to focus. But if the opposite is true, and those 95% are in coding and medical necessity and things of that nature, then companies like Protego are really like a great place to go to try to figure out how to solve those issues. But the first challenge is like identifying the issue and then looking out there at the number of solutions that can meet it. Yeah, Elion I found to be a great reference. They're new, but they're growing in terms of specific problems, and the vendors out there that are addressing them. They become a great aggregator for different tech solutions. But at a certain point, you got to jump in and try. So I would say being willing to try, even if it means doing the work alongside of the software at first to prove that you believe in it and that it's coming up with the right answers. But the most dangerous thing in my mind is doing nothing, because this wave is going to pass you by. And if you're not addressing these things in real time and your peers are, then guess where UHC is going to look when it comes time to make up that quarterly earning gap true, right? They're going to look to the practice that hasn't been appealing because they don't have the same tools as their peers. So just like payers are, payers have this thing called risk adjustment, right? Where at the end of each year, if their peers had sicker patients, which basically just means they sent doctors into the home to code their sickness levels, then you literally pay money to your competitors, right? Which is kind of a crazy thing, which is obviously the force driving them to constantly prove that their members are the sickest. We're going to see something similar with providers, right? Which is there will be providers where technology has bridged those gaps and made them far more effective and efficient than their peers. And there will be those that have not taken that leap that will be the slow antelope on the plains of Africa waiting for the lions to come catch it. So I think it behooves all organizations to throw their hat into the ring and at least try to use these new tools to improve their processes and to make their practices more productive, more profitable, and to save patients from these costly denials like the ones that impacted my brother.
Yeah. I mean, bottom line, act now. I've said for a while now, AI is not a nice to have anymore. Given where margins are at, given how expensive labor is, you need it to keep up. So I'm gonna ask you one more question, then give you the floor for final parting advice. I mentioned kind of where I think 26 is going, but I want to hear from you as someone who's been even closer to AI. What are the next big features or capabilities you think will define revenue cycle automation here over the next year or two?
I think in general that the path for AI, now that it can answer every question, is for it to self-regulate and answer those questions correctly. The obvious reason that it answers as opposed to saying, I don't know, is would you use it as often if it expressed its own uncertainty? Like, well, there's also questions that I don't know the answer to. Why would I go to ChatGPT for that? So there's a built-in financial incentive for these large language model companies to always have the AI give the answer. And that's dangerous in clinical care and in rev cycle and in many other places. So the extent to which individual companies can locally host and tweak that AI to be a more to provide a more honest answer, even when the answer sometimes is, I don't know, or the AI companies themselves can regulate in order to ensure that they are giving factually accurate answers and not providing you with nonsense and then pretending that it's true. how often have you told ChatGPT, well, did you think about this? And it's like, oh, you're totally right. And it's like, well, why did I have to tell you that for you to self-correct?
And the way that it says it is exactly that, right? It says, Corey, you're a genius. You're
Right.
totally right. Because to your point, financial incentive is to keep Corey happy, to keep Corey on the platform. Because then I have more users, more active users. My company's worth more money. That is scary on another level to me. So I love that you're talking about regulation, but sorry to interrupt. Go on.
No. And I mean, I think the takeaway from the conversation about what providers should be doing is if you're not at the table, you're on the menu. And it would behoove you to figure out where that pain lies for your organization and figure out what companies out there can help you address that need. I'm fairly sure that's something that you can help with, given your background. So you would be my first recommendation for the phone call for them to make.
I didn't pay him. I didn't pay him to say that. Just so you know. Elliot, your shout out to LEN too. LEN's good. They're growing. They got a ways to go, but I do think they're more thorough than a lot of other places. But
For sure.
thank you.
And the other, I guess the call will be for sure if folks are interested in what we're building and just want to have conversations and whether or not it's the right fit for your organization. We learn a lot from talking to people who are knowledgeable in the revenue cycle space, and we really aim to be thought leaders. And along those same lines, there is a piece of legislation that I'm trying to shape and push into some context in Congress. And so if there are folks within your user base or listener base that have deep knowledge of healthcare legislation, particularly related to denials, I would really welcome the chance to connect to see how to move this thing forward and try to remove at least some of the legislative barriers to people being treated fairly by health plans.
Yeah. Well, Corey, thank you for taking the time today. That may have been it, but I'm going to give you another opportunity just in case. Any final parting advice to our listeners?
I would just say change is not optional. It's a reality of human existence, and it's never been more significant than now. When you speak to folks who are 70 and up and you ask them, what's the biggest change in your lifetime? Almost across the board, they say AI. And so I think it behooves all of us to figure out how AI can serve us and not push it into the corner of, this is not something I want to deal with. I just think it's coming whether we like it or not. And the more we understand it and the ways it works and the ways that it doesn't, the more informed we can be as consumers of it and the more thoughtful we can be about where we want it to play a role in our lives and where we want it to be on the sidelines. So that would be my general AI advice.
I think it's good advice. So thanks again, Corey. Appreciate you taking the time today. And until next time.
Great to see you. Thanks for having me.
That's a wrap on yet another episode of Vendor Voices. Huge thanks to our guests for their insights and to you for listening. If this episode gave you something to think about, share it with your team. If you'd like to suggest a specific topic or guest, feel free to reach out to me on LinkedIn or at rdowns@realpartnersconsulting.com. Please rate and review, and be sure to subscribe to never miss an episode. I'm Ryan Downs. Thanks for tuning in.